I'm going to try to take maybe a little higher level view on immunotherapy for childhood cancer. I'll talk about some of our CAR data because it is really exciting, but there's a lot of excitement, around the whole arena of immunotherapy. 2013 Science Magazine, Immunotherapy for Cancer was the advance of the year. I mean, for people who have been pounding away at this since the 80s and the 90s, and just to finally see, us reap some benefit, it's just really exciting. And, we all think we're looking at the tip of an iceberg, but we don't know for sure. We hope we are. And so you're going to feel, hopefully, some of that enthusiasm from me and optimism, and I hope I can convince you that it's warranted. So I'm hitting the advancer. There we go. Okay, so if you want T-cell responses to cancer, there's two fundamental ways you can get them. You can say they're already present. The patient has already found it's cancer. The immune system has already recognized it, and it just isn't strong enough. And you can try to augment them. Now, how can you do that? Well, that's tumor vaccines, these checkpoint inhibitors, CTLA-4, PD-1, using tumor-infiltrating lymphocytes, take them out, expand them, give them back to the patient. The fundamental premise there is the patient already has an immune response. It just needs to be activated. Now, for that to work, there has to be an antigen that can be recognized. And the tumor has to advertise that antigen in a way that the immune system can see it. And that means they express this molecule called MHC. It means that your patient has to have an immune system that's capable of responding. And many of our patients, of course, have been often beat up by chemotherapy that probably limits that. And because tumors, we've learned now, during the early phases of their growth, create sort of a shield around them that protects them from the immune system, even if you augment responses, if you don't do anything to break down that shield, to alter the immunosuppressive milieu, you may not get as far as you otherwise would. So people are doing that with the checkpoint inhibitors, or you may just have to, go in with lots more numbers, and people do that by expanding T cells. Okay. So let's talk about what could be the targets. And there's a guy named Bob Schreiber at WashU who's really been the leading thinker in this area for the last 10 or 15 years. Immunologists used to argue ad nauseum at this question of immune surveillance. Does it exist? When a patient gets cancer, has their immune system played any role in modulating that cancer? And perhaps in some of us in the room here that don't have cancer, has our immune system maybe eradicated incipient cancers? There was some evidence that this was true. If you took mice and you made them immunodeficient, for instance, they would get more cancer. And so they argued for years about whether or not immune surveillance exists. And at this point, I think there is a general consensus that yes, during the early phases of tumor cell growth, the vast majority of tumors induce some kind of an immune response. In some cases, for the lucky ones, we don't know how many, the immune system is capable of eradicating it. But for those who are going to go on to develop cancer, that initial immune response is followed by a period of so-called elimination, where the two are living together sort of in dynamic equilibrium, détente. And during that time, the pressure that the immune system is putting on the tumor selects for the most immune-evasive part of the tumor. And so by the time the patient walks through your door with cancer, what you have is a tumor that's already been sculpted to be able to evade the immune system. So part of what it takes to get a cancer to grow is it has to have figured out how to escape the immune system. What are the antigens? What are really the targets that the immune system can use to identify cancer as its target organ? And there are these molecules. They're supposedly ubiquitous tumor antigens. They're on almost all tumors. The problem is they're also on normal tissues to some low level. There's this class of molecules, the cancer testis antigens, which seem to be something that's only expressed in cancers and germ cells in the testes. And so in the germ cells, they're sort of camouflage from the immune system. These things come up as a result of demethylation of the genome, which cancers like to do to turn on genes. And we really don't know what they do, but we know that they can be targets, and I'll show you an example of that. And then the new kid on the block are the mutated proteins. So when I look at the data from Charles's elegant work, and he shows us all of these mutations throughout the genome, you can think about targeting those things by giving them a tyrosine kinase inhibitor. But the immune system may also be able to recognize these mutations because they're not found in any other cell in the body. And proof of principle for that has recently been demonstrated fairly elegantly. So that's encouraging, maybe we can target these things. But then, of course, we've got this data that says, okay, but if you just look at cancer in general and you say how many mutations are present, and in this case, we don't care if they're passenger or driver, we're just saying how many abnormal proteins are in there that the immune system might recognize as foreign. You can see that the tumors on the left side with the lowest mutation rate tend to be our pediatric tumors. So it gives one pause, and it makes you wonder, maybe these tumors are less immunogenic than the adult tumors, like melanoma, one we know has been very amenable to immunotherapy, happens to have the most mutations too. So this is an unresolved question, but it does make you worry about taking an approach that just asks to increase natural immune responses in kids with cancer. Well, how might you do that? Let's say you wanted to do it. Well, one way is to give these checkpoint inhibitors. So this is the only trial of a checkpoint inhibitor done in kids so far, and this is the old checkpoint inhibitor, anti-CTLA-4. Basically, it blocks signaling via this molecule that is an inhibitor of T-cell activation, and when you block that signaling, you essentially turn the immune system on, make it more prone to autoimmunity. You sort of take the brakes off. So we treated 30 kids with refractory cancer with anti-CTLA-4, and we saw the side effects that you see in adults. We really did take the brakes off their immune system. This was not an easy treatment for these kids. We saw autoimmunity that sometimes was quite significant. You can see them listed here. I didn't know if we'd see it. I didn't know if the kids were even going to be prone to autoimmunity when we treated, but indeed they were. That might have led you to think we'd see something great in terms of anti-tumor response, but we really didn't. 11 of the kids enrolled on this trial had melanoma because this is what the drug was being developed for in adults. None of those had an objective response. In adults, the objective response to this in melanoma, which is why it was approved by the FDA, is not that great either. It's about 15% in the initial studies, 8% in the follow-up studies. But you can get clinically meaningful improvement in long-term survival despite the relatively low response rate. But 0 out of 11 for kids, it just isn't good enough to slow down the growth of the tumor. The thing needs to shrink and disappear for it to be meaningful. And we saw 0 out of 11, 0 out of 19 objective responses in non-melanoma. This is our best response. This young lady had melanoma of the skull. You can just see these are nasty, nasty tumors. And, it slowed things down. I think she benefited from the therapy, and nothing much else is active against melanoma, but it certainly wasn't a home run. Another way to try to, take the brakes off or try to amplify endogenous immune responses is with vaccines. And we've spent a lot of time developing vaccine-based therapies for childhood cancer. I show you this slide just to point out that it's pretty complicated to give a tumor vaccine. We're basically collecting cells and making dendritic cells and pulsing them with this cytokine cocktail, and this is the antigen we're using, and depleting Tregs, and we really did the best we thought we could, okay? And this is for patients who had metastatic sarcoma. Now the point here is that we didn't treat patients when they had already recurred. The thing we do know about vaccines is they're safe. They generally don't cause the side effects of some of these other immunotherapies we're talking about. So what we did in this case was to treat these patients after they finished standard therapy, when they were in remission with the vaccine. And this is the intent to treat all the patients enrolled on this trial. Only about a third of them ended up getting the immunotherapy because some progressed early and were unable to. This is all metastatic and recurrent sarcomas here. So it's a survival curve that looks favorable, but you don't know quite for sure. When you divide this up into those that did get the immunotherapy, the 29 who did get it versus those that didn't, that begins to look like a pretty nice survival curve for patients with metastatic and recurrent sarcomas. The patients with newly diagnosed Ewing's and rhabdo were the ones that did the best on this trial. This is their survival curve. That looks really good for 5-year follow-up. And it turns out that the patients who had a response to their tumor lysate, this is the gemisch of their own tumor. If you test it in the test tube, do they recognize their own tumor, actually were much more likely to be survivors. So now when you measure the immune responses after a tumor lysate type approach, this is what you get. And these are considered positive up here, okay? Not a very potent approach to inducing immunity. Okay, so let's say that augmenting existing immunity has its problems. And it might be in part because our pediatric tumors are not all that immunogenic. And it might be because they grow really fast. And the immune response we can get with this approach is pretty low quantitatively. So how else might we go about this? Well, we might create new immune responses. Let's just completely teach this immune system to do something that it would never do naturally. Okay, and that involves the use of synthetic biology. Now, synthetic biology, really the first good example of clinically meaningful synthetic biology was monoclonal antibodies, okay? And of course, the single immunotherapy that's been demonstrated to improve outcomes in childhood cancer is the use of monoclonal antibodies in neuroblastoma now. So this isn't a new idea, but it's new that we're beginning to use this synthetic biology, gene therapy, for adoptive T-cell therapy, both in the form of chimeric receptors and in the form of T-cell receptors. So Shannon gave you a great introduction. These are the chimeric antigen receptors here, and it's a Frankenstein molecule. This doesn't happen in normal circumstances. You put this antigen binder with the T-cell signaling apparatus, and you express it in a T-cell. Another way you can go about using synthetic biology is to say, I'm not going to make this hybrid molecule that is MHC, I'm sorry for the lay people in here, but it's MHC independent. I'm going to just use the regular T-cell receptor that T-cells usually use. Now, the differences between these approaches are significant. So the TCRs require the processed peptides. This recognizes intact cell surface antigens. So the T-cell receptors have to be developed for each tissue type. So if you make a T-cell receptor against a particular tumor, it's only for patients with that tumor and that tissue type. So you're already saying, well, it's only going to be relevant to a third of the population or 20%. It's like a blood type. Okay, so it's much more complicated in terms of developing a therapy that is going to be exportable. The cars get out from under that problem because it is not MHC restricted. The other thing is, so far, people have only made T-cell receptors that are natural, and so we're relying on the natural signaling apparatus of the T-cell. CARs, however, have really been much more aggressive in that we're engineering into the vector, into the construct, TCR zeta, that is signal 1 for the T-cell, and the co-stimulatory domain. And I think that's why we're seeing such potent activity and sometimes such significant toxicity. These things are absolutely supercharged T-cells, unlike what Mother Nature gives us. And it may be that's what you need to cure cancer. But it really is sort of a step beyond. So I'm going to blow quickly through our work using an NY-ESO TCR and some of our work using 2 different CARs with different co-stimulatory domains. I'll go quickly through our CD19 CAR data because Shannon set it up so nicely. I don't need to give you very much of a background. Ours is a lot like the Penn construct, but it differs in one important detail. And they use something called 41BB for their co-stimulatory domain, and we use CD28. And I think it might be really important. We make the cells with a 9-day or so process. There's a lot of talk given to how hard it is to do adoptive cell therapy, and it'll never be exportable. And I have to tell you, I think that's a bit overblown. Bone marrow transplant is complicated. Treating kids with leukemia is complicated. If things work, the technology will be developed to support it. It may not be available in every hospital, but I think a hospital that does significant stem cell transplant would be able to do this. We were able to do this readily, 90% feasible in our population. Here is our results with 20 consecutively enrolled patients with pediatric ALL, and you can see the vast majority of them had a complete response, and many with an MRD negative complete response. Some of those were associated with high-grade cytokine release, and some were not. So you don't have to have high-grade cytokine release to have a response. Unlike the PEN CAR, which persists for several months, our CAR gets in and gets out. It expands about day 7 or 14, it peaks, and then it disappears, coincident with B-cell recovery. Now, this is what I want you to remember. Remember I was saying 0.014% of T cells were tumor reactive? Look at this. Patients have tumor reactive T cells that are way high, okay? Many of them are greater than 1%. And in this young man, 79% of his T cells are tumor reactive. We're talking logarithmically increased potency in terms of the immunotherapy. This is what you see. You put the cells in, they expand. In our hands, they contract. Here's the leukemia, it disappears. Here are the normal B cells. We see an eradication, and then we see B cell recovery. We also see these go to the CSF, and we have seen clearance of blasts in the CSF as the CAR cells go in there. Most of our patients went on to get a transplant, so I cannot tell you, I can't say anything about whether this could keep people into remission. It makes you worry, the fact that the CAR cells don't stick around, that you wouldn't, but we really don't know that. 2 patients did not go to transplant. These 2, their home hospital, home treating teams thought they were too ill to go to transplant. Both recurred, but both with loss of CD19. So this issue of the tumor being able to mutate around the immune pressure is going to be a real issue that we're going to need to deal with as our immunotherapies get more potent. This is the cytokine release syndrome, all the cytokines that go up, and this is one of the patients that we treated with tocilizumab. Penn made this discovery early, and really the rest of the community has completely adopted this. We agree 100% that there's a lot of cytokines that are elevated in this syndrome, but the response to tocilizumab is impressive. And this, to our mind, implicates IL-6 as one of the critical players in this syndrome. I do want to talk a little bit more about cytokine release syndrome because, it unfortunately got a fair amount of press right around the time of AACR last year. A couple of deaths occurred at a hospital due to cytokine release syndrome in adult patients, and it shut down the CAR trials. And I will tell you, the investment community and the pharmaceutical community was really running scared. And at that point, we decided, as pediatricians, we know how to collaborate and get together and take on these clinical problems. And so what we did was to bring together experts from a variety of institutions that are involved in this type of therapy and said, let's pound out what goes on with these patients and what's the best approach to treating them. So these were investigators from Bethesda, Seattle, Houston, and Philadelphia, where Shannon is. And the first thing we needed to do was to establish a grading system that we all agreed on. The CTCAE grading system was really not relevant to this type of cytokine release syndrome. So we needed to all be talking about the same thing in terms of how sick a patient was or wasn't. And so we've put this out now in blood, and I refer folks to it if they get involved. Sometimes you do see cytokine release syndrome with other therapies as well. Now, the grading system, though, we think is really important because once you know what you're dealing with and how severely ill the patient is, then you can dictate your therapy. And so we've put out now a treatment algorithm that is dictated based upon our grading system. And, it really is important to ask yourself, am I going to tolerate grade 4 CRS? Or am I going to shut this thing off at grade 3? Now, one question would be, why don't you shut it all off? Well, you don't want to shut it all off because we think that the cytokine release is part and parcel of the immune response. So you want to let the patient have enough cytokine release, but not too much that you put them at undue risk. And so we've recommended treatment of all patients with grade 3 CRS with the goal of preventing grade 4. And for patients with comorbidities or older age, we recommend treatment at grade 2. I hope that this will be adopted, some kind of standard approach will be adopted across institutions, because if we all do it willy-nilly, we run the risk that this otherwise very effective therapy could be shut down for toxicity that could be avoided. These patients are sick, but we know how to take care of sick patients, but you need to do it in a thoughtful and systematic way and gather the data regarding the efficacy. So we see that it's feasible to give this therapy in 90% of patients. One patient who was considered non-feasible because his cells didn't grow to meet the dose we gave went on to develop a MRD negative CR. So it's surprising how easily you can grow these cells from even children with refractory leukemia. As Shannon said, the DLTs are primarily related to cytokine release and can be treated with toci and/or steroids. We also did not see graft versus host disease. Our CR rate is 70%. It is an intent to treat, so everybody who was enrolled on the trial was given cells, and so the denominator I think you can take as a real denominator here. And we saw correlates, CAR T-cell expansion correlates with both response and grade of CRS. So let's talk about the antigen escape, because it is a really important problem that we first started to see after blinatumomab, some CD19 negative leukemias. I mean, this is unheard of 10 years ago. All pediatric ALL was CD19 positive. In fact, the MRD system that the COG uses to grade MRD, was hinged on CD19. And now that we're starting to use CD19-directed therapies and the tumor is outsmarting us, we're going to have to completely change the whole flow approach to be sure you don't miss these. So this is an example of a patient who had received CAR therapy, and you can see before CAR therapy, high CD22, high CD19. After therapy, this is what comes back, leukemia cells that have plenty of 22 and lost their 19. So we've spent a good deal of energy in the laboratory in creating a chimeric antigen receptor that would target CD19. It's important to note that just because you have an antibody doesn't mean that you're going to have an active CAR. You usually have to try several antibodies in order to get this thing to work. This was led by Rimas Arentis in our group and Walid Hasso and published in Blood in 2013. So our antibodies that we tested were these three. It turned out this was the winner. I want to show you that just like CD19 is ubiquitous on pediatric ALL, so is CD22, albeit at a lower site density. And whether that is going to end up being a major problem for targeting it, I don't know. But there are not as many CD22 molecules on a leukemic cell as there are CD19. So anyway, we went through and did a whole lot of testing. This is kind of fun because, usually academic laboratories can't make drugs. Right? You have to go to the company to make a drug. But because this is all gene therapy, it's just a different gene construct, you can do this in your own lab. You can set up all the different possibilities, and then you pick the winner. And in this case, surprisingly, this was the winner. I thought these would all be similar. They really weren't. This was a clear winner. This is just an example. In the mice, you can see how the CAR using this specific single-chain FV was so much more potent. This is leukemia in mice that glows. So much more potent than this one, even though this one had higher affinity. As far as we can tell, this CD22 CAR is really equipotent to the CD19 CAR. And that may seem like, oh, well, wouldn't that make sense because you made it the same way? It turns out there's a whole lot of CARs out there, and very few appear to rival the potency of the CD19 CARs. Now, let me talk a bit about using T-cell receptors here. And I do this because everybody wants to know if immunotherapy is going to work in solid tumors, and that's what I want to know too. Because I agree with you. I mean, it's great that we have this wonderful news for leukemia, but what about the DIPGs, and what about the refractory Ewing sarcoma? And believe me, we are working very hard to try to bring this to solid tumors. And I want to show you some early clinical results targeting this NY-ESO-1, not with a CAR now, but with a T-cell receptor, because I think it really hones in that this immunotherapy can work in solid tumors. I have to introduce it by saying this is a very special receptor that targets the epitope, NY-ESO-1 epitope, in the context of HLA-A2. So only 30% of the folks with in this case, synovial sarcoma, are going to be eligible. Furthermore, this T-cell receptor was made by a company and affinity matured with lots and lots of effort. So this is not something we can do in our laboratory. We need to work with academia for these T-cell receptors. They're much more complicated, I think, than the CARs. But with that in mind, we have treated patients with this genetically engineered T-cell receptor, and here's a vignette. This is a young adult who had synovial sarcoma of the neck, initially misdiagnosed as a Ewing's. That meant she got a lot of chemotherapy. She got the tumor resected, eventually got more chemotherapy, had a local recurrence followed by a very, very impressive distal recurrence. Here's her chest CT when she was enrolled on our trial. These had been biopsied, and they were NY-ESO positive synovial sarcoma, just to show you how many tumors she had in her lungs when she went on the trial. I felt almost ethically conflicted putting her on this trial. I felt like we were giving her false hope. I really never dreamed that the therapy would help her. And she got these cells. We do give a preparative regimen, but the dose of this chemotherapy is very low compared to what she had been receiving. So I do not believe we can attribute her response to chemo. She happened to get a virus the day before the cells went in, and I'm still not sure that didn't help things. But the cells went in. She developed a lot of the symptomatology you see with CAR therapy, and we don't usually see that with TCR therapy. It wasn't as severe. She stayed on the floor with a bit of nasal cannula oxygen. But again, we saw this dramatic expansion of the engineered cells. Something like 10 to 30% of her T cells were now specific for the NY-ESO. And here's her chest CT at baseline. I showed you she had all those masses. 2 days after she got the cells, it just lit up like a Christmas tree. This is not the kind of thing you see with chemotherapy. It was not tumor progression. This is inflammation surrounding each and every one of those tumors. And she developed shortness of breath and symptoms. But when we saw this, we thought, wow, this is exactly what we need to have happen. If you're going to treat cancer, you've got to have a potent immunotherapy, and this kind of stuff is what you have to have. She tolerated it really quite well, and by day 28, nearly all of these things were gone. She was left with a couple little nodules and ended up with a complete response to the therapy. For 9 months, completely disease-free as far as we could tell. After 9 months, she had a recurrence. It was NY-ESO positive, and it slowly grew over the course of the next 5 months or so. A year and 2 months after she got the initial therapy, she received a second course of therapy and did not respond to that, unfortunately. She's still doing quite well a year and 9 months from the first therapy, although she does have small nodules in her lungs, but not back to where she was. So this is another patient, a large necrotic mass. This is the kind of tumor you think, well, T cells can't get in there and eradicate that. They're going to get caught up in all the necrosis. But in fact, a very nice partial response in this young lady, ongoing. And so far, 4 of 5 patients treated with synovial sarcoma with this engineered T cell receptor have had objective and meaningful responses. And the responses occur over the course of several months. They slowly go away. It's not the kind of pattern that you see with chemotherapy where you get your maximal response within about a month. So I think it's pretty clear this is not related to the chemotherapy. And it provides me proof of principle that you can use adoptive cell therapy in non-melanoma solid tumors. You don't have to use IL-2. The previous study had used IL-2 with this. Now, so it's exciting, but we're still, this is, as I said, it's one synovial sarcoma, very rare tumor. You have to be NY-ESO positive, that means 70% of synovials, and you have to be A2 positive. So all told, only 1 out of 5 synovials who call me are eligible for this therapy. So it isn't the kind of thing that you're going to be able to export. It gives you proof of principle, but you need to be able to broaden this. And so this is where everybody, all of us, very much want to move the CAR therapy to the solid tumors. And we're working very, very hard on it. But it is going to be a major challenge. The first major challenge is the target. Okay? Very few targets, if any, are tumor-specific, especially cell surface molecules. I mean, the mutations that Charles identifies, some of those are tumor-specific, but those are MHC-restricted. Most of those are not on the surface of the tumor. And in the old days, when immunotherapy wasn't very potent, you could target these kind of things. You could do a vaccine to survivin, and survivin is on some normal tissues, and you didn't see any toxicity. Well, that was because your immunotherapy wasn't very potent, okay? Now that we have more potent immunotherapies, the stringency with which you have to pick your target has really gone up. Some examples are that the carbonic anhydrase CAR that was developed for renal cell carcinoma got shut down because there was a little bit of that antigen on the biliary tree. This was particularly sobering experience that came out of both Carl June's group at Penn and Steve Rosenberg's group at NCI. Both of them had made MAGE-A3 T-cell receptors, similar to the NY-ESO that I'm talking about now. And both of them saw fatal toxicity in the first patients enrolled, one due to cross-reactivity on the heart of a peptide that was buried in another gene called Titin, and Steve Rosenberg saw fatal neurologic toxicity in 2 patients related to cross-reactivity of a peptide that was buried in the brain. So the protein wasn't in the brain. They screened the brain before they did the therapy, but it was the peptide, the little small 9-mer. So we now have algorithms to be able to screen, to look for these kinds of toxicities. But the point is that now that your immunotherapy is potent, you got to be really careful about how you pick your targets. And, you know, very few truly tumor-specific antigens exist. CD19 is not a tumor-specific antigen. It just so happens that the cell that expresses CD19 is a B cell, and we can live without B cells for a period of time. Now, then you start to kind of fudge and say, okay, well, maybe I don't need a tumor-specific, maybe differences in the level of expression are enough, right? If I have very high-level expression on my tumor and low-level expression on my normal tissue, is that enough? And the answer is we don't know. Okay, those are the kind of studies that are being undertaken right now. I like to think about this, you know, from a military analogy. And, you know, trying to target oncogenes, if you think about fighting a war, is a lot like intelligence gathering. The fundamental premise is you need to learn everything you can possibly learn about your enemy, what that enemy needs to survive, and try to deprive them of whatever growth pathway or oncogene that they have basically come to rely on. And it's so essential that whatever target you pick, it has to be a driver, right? It has to be essential for survival. But when you turn that driver off, you basically are starving the tumor. In some cases, you may be killing the tumor, but usually you're starving the tumor. You're basically inhibiting growth. And it isn't so common that when you turn off these oncogenes, the tumor just kills itself. Sometimes it does, but oftentimes you will see it stops growing, okay? Now, your risk of that type of an approach is that your enemy will be weakened, but it may not be killed. And over time, what we see with a lot of these targeted therapies is that if the thing isn't killed, there's going to be an alternative supply route opened up. And especially for pediatric cancer, you know, you got to kill that thing, or it's going to find a way out. And I think the reason why immunotherapy is very important, and I think all of us should embrace it for the power that it has, and that is that these things kill. They are very potent killing weapons. CTLs are the killers of your body. That's, you know, what we have to kill virally infected cells. So the potency of the killing is really quite remarkable. The targets that we need to identify, they just need to be able to identify the enemy. They do not need to be required for tumor survival. CD19 may be used by the leukemia cell, but it's not an essential cell, as you can see. So most of the time, that's going to be sufficient. Now, we are seeing immune escape. So with immunotherapy, the primary risk for immunotherapy is collateral damage. So this issue of off-target toxicity is really the big thing. We have not seen evidence of inherent resistance to CTL killing. Most likely, the resistance is going to relate to loss of the target. But inherent resistance to immune cell killing appears to be limited. So I'm just going to throw up this kind of provocative picture, AKA the Harry Potter series. And so here is Lord Voldemort, when he's big and strong and, everybody's afraid of him. But by the time we get to the Goblet of Fire, this is Lord Voldemort, right? Okay, baby Voldemort. And, who would have ever thought, if you weaken Lord Voldemort to this point, that he would come back to threaten anybody? And I think sometimes our genomic therapies can get us there, but we need that last shot. Because by the time we got to, I forget which book it was, the guy comes roaring back. And it wasn't until we had the killing curse and the destroyed Horcruxes, etc., that you had Voldemort's death. So I say use the immunotherapy. They are potent killers. They can give the nail in the coffin. And there's something that I think we can really benefit our patients if we learn how to use it.